Perfect. So welcome to DC TrapMed Talks. Today we have Dr. Tuan Tran, who's going to be discussing drug-resistant malaria. Tuan studies the host response to malaria in endemic populations. While a graduate at Emory University, he evaluated immune responses to malaria vaccine candidate antigens in residents of the Brazilian Amazon. After completing his residency in internal medicine and Johns Hopkins Hospital and infectious disease clinical fellowship at NIAID, he trained in Peter Crompton's laboratory, where he studied naturally acquired immunity to falciparum malaria in a cohort study conducted in Mali. He is currently an assistant professor of medicine and pediatrics at the Indiana University School of Medicine, where he studies both naturally acquired and vaccine-induced immunity to malaria using systems-based approaches. By performing integrative analysis of high-dimensional immunological data generated from well-designed cohort studies, his group aims to identify molecular predictors of malaria outcomes and elucidate the mechanisms governing immune responses that protect the host from infection and disease. His lab has been funded by the Doris Duke Charitable Foundation and NIAID. So with that, I'll let Tuan take it away for a talk that I've been really looking forward to.
Thanks, Adrian, for the introduction. And thanks, everyone, for coming to the new talk.
Tuan, and as per usual, we'll leave a little bit of time at the end for questions, and people can type questions as they go along in the chat box, and I will ask them to you at the end.
Okay, excellent. So thanks for the opportunity to speak. And as a disclaimer, my focus of my research is on a human immune response to malaria, so I'm by no means an expert on malaria drug resistance, but this was a very good opportunity for me to review and update myself on the literature. So without further ado, advance the slide here. Okay, so malaria remains a global public health threat with over 240 million cases and causing 629,000 deaths worldwide in 2020. And both of these numbers are up since 2019. With 6% and 12% increases. The majority of these cases or increases were reported in the WHO Africa region over here. And so just to review, malaria infection begins in humans when a infected female Anopheles mosquito bites an individual and injects sporozoites, which within minutes goes via the bloodstream to infect liver hepatocytes, where they develop and progress over about a period of 7 days in falciparum, and then multiply and rupture from the hepatocytes as thousands of merozoites per hepatocyte. And these merozoites can individually infect an erythrocyte and beginning the blood stage of infection. So in the early blood stage, when it's in the ring form, the parasite is T phates. It can either develop sexually into male and female gametocytes, and then be subsequently taken up by another mosquito and begin the process all over. But more likely, it's going to develop within the red blood cell and multiply into a trophozoite schizont, and eventually rupture, producing a couple of dozen merozoites, which each of these daughter merozoites can infect another erythrocyte and further propagate and multiply. And so, since this is a drug lecture, all of these drugs listed here that are known as antimalarials affect the blood stage. And the ones in the blue box, the antipholites, the iminoquinolones, and the naptoquinones also affect the liver cells. And only primaquine, and not listed here, is tefenaquine, affects the hepatocytes in terms of the dormant stage called the hypnozoites in P. vivax and Valley malaria. And so the focus of this talk will actually, I will talk more about chloroquine to give you historical context of drug resistance, as well as Artemisinin, which is an endoperoxide antimalaria. And so malaria drug resistance has been in the popular media lately after drug resistance was reported in African patients in scientific journals last year. And this is all beneath the backdrop of the COVID pandemic, which you probably heard about. And so this has stressed the healthcare systems globally which has affected both malaria detection and treatment in sub-Saharan Africa. And so first, I just want to give you some technical definitions from WHO, some terms I've been using. So treatment failure is the inability to clear parasites from the patient's blood or prevent their recrudescence after administration of an antimalarial. And many factors can contribute to these to treatment failure. So incorrect dosage, poor patient compliance, poor drug quality, interactions, resistance. But anti-malaria resistance per se is the ability of parasite strain to survive and multiply despite the administration and absorption of drug and given doses equal to at higher than recommended as long as it's well tolerated. And then multi-drug resistance in terms of malaria is that usually this refers to resistance to chloroquine, sulfadoxone, pyrimethamine, and a third antimalarial compound. And then lastly, which is going to be the bulk of this chart, is called Artemisinin partial resistance. It's delayed parasite clearance following treatment with an artesunate monotherapy or with Artemisinin combination therapy, or VIX combination therapy. I'll first start off with a case, and this is a prototypical case derived from multiple case reports. It's a 28-year-old male agricultural worker with no prior malaria history, presented to a local malaria post at the Myanmar-Thai border with a several-day history of fevers and headaches. Vital signs and physical exam were normal without any findings suggestive of a severe illness. A rapid diagnostic test was positive for P. falciparum, and an individual was treated for uncomplicated falciparum malaria with artemether lumefantrine orally, with the first dose directly observed. He was sent home to complete a 3-day course. And so now I'll leave you with this initial vignette to ponder, and I'll delve a little bit into the history of drug resistance in malaria. And so, unfortunately, like with most antimicrobials, resistant to antimalarials appeared relatively quickly after each one of these drugs was introduced, starting with chloroquine, or ignore quinine, given that Plasmodium wasn't even identified as a causative agent of malaria by Laveran until like 1880. But I'll highlight a few for this talk. So as you can see, chloroquine was introduced in the 1940s, saw heavy use for decades despite reports of resistance starting in the 1950s. Sulfadoxine pyrimethamine, or SP, was introduced in the 1960s as a potential replacement, but widespread resistance quickly followed. And its use has been fairly limited for scenarios such as intermittent preventive therapy during pregnancy or seasonal malaria chemoprophylaxis. And then artemisinins were discovered in 1970s and has gradually be introduced for more global use starting in the 2000s, particularly in combination with longer-lived partner drugs, as well I'll explain later. And it's also experiencing partial resistance, and I'll talk about that later. And then lastly, I'll just mention the combo drug Atovaquone-proguanil, also known as Malaria. So down here has resistance reported 5 years after it was introduced. So resistance to chloroquine is thought to have risen at multiple sites and spread globally. So both in Asia and in South America and Colombia. And it's thought to have seeded the introduction of chloroquine-resistant parasites in Africa, cared by individuals with the infection. And so an important process targeted by multiple antimalarials in asexual blood stage parasites is the degradation and detoxification of hemoglobin. And so what the parasite does is, this is a infected red blood cells with the Schizon stage, multiple parazoites. It's within a parasitoporous vacuole, and it detoxifies hemoglobin. So the parasite breaks up alpha and beta hemoglobin and uses that the amino acids for its, to help it grow. But in the process, it releases free iron-containing heme moieties that are very toxic. And so it tries to detoxify it within these humazoan, which is this brown substance here. And so the four aminoquinolones, notably chloroquine and imodiaquine, are thought to act primarily by binding humazoan crystals after actively growing at surfaces, thus preventing further incorporation and detoxification of free heme. So it blocks this step here. So chloroquine is conferred by mutations in the P-phosphorin chloroquine resistance transporter, or CRT. It's localized to the membrane of the parasite, of the digestive vacuole of the infected erythrocyte, and in chloroquine-resistant parasites, this transporter confers resistance by pumping chloroquine out. So chloroquine can exert its inhibitory effect on hemozoan. So, and this discovery was, of course, spearheaded by Tom Williams' group at the NIH, as well as Chris Plow at University of Maryland, and researchers at Mali who first noted the presence of this molecular marker of chloroquine-resistant malaria in Mali. And so it's also known as another transporter, MDR1, mediates susceptibility to multiple antimalarials by pumping molecules from the parasite cytosol into the digestive vacuole. And so having a mutation in MDR2 actually enhances chloroquine resistance. So this cartoon shows you how both having mutations in CRT and MDR can really decrease the amount of chloroquine within the digestive vacuole. And so resistance to chloroquine, like I said before, spread from, arose in multiple sites, but really the spread was from Southeast Asia to Africa. After chloroquine resistance was pretty widespread, countries started using SP, or sulfadoxine pyrimethamine, and resistance to this medication developed, after the first year of clinical use. And so the mechanism of SP is the sulfadoxine component inhibits dihydrooctanoate synthase, and then pyrimethamine inhibits dihydrofolate reductase, respectively. So both of these enzymes function in the folate pathway, and specific mutations within each of these enzymes confers resistance. And so, like I mentioned before, SP is primarily limited to use in intermittent prevention in pregnancy and also in seasonal malaria prophylaxis. And it's also been partnered with artemisinin-based medications, so particularly artemisinin. And so you can see here that the pyrimethamine resistance also tracks pretty well with chloroquine, where it starts in Southeast Asia, then spread over to Africa, and then there's multiple points of independent development resistance in South America. And so the next drug that had global use is artemisinin, which is currently the first line treatment for people suffering from malaria. And so the history of this is that artemisinin was extracted from sweet wormwood by Yu Tu in the 1970s. And for this, she won a Nobel Prize in 2015. And this is what sweet wormwood looks like. And this is what artemisinin looks like molecularly. And so it blocks the ring stage and sexual parasite stages, and it targets proliferative trophozoites and schizons. It has very rapid killing. So you should, in normal situations, clear your parasites within 2 to 3 days. It does have a very short half-life, however, and so it's typically partnered with longer-lived antimalarials, such as lumefantrine, methicillin, and pircoquine, used in artemisinin-based combination therapy. And so the mechanism of artemisinin wasn't exactly known. And it was primarily thought that because it has this this peroxide bridge here, it essentially becomes activated by heme, and then it releases free radicals that alkylates proteins within the parasite, and these alkylated proteins cause damage. And it wasn't until a few years ago that two groups independently showed like the level of what's called proteopathy that develops with artemisinin use. And so essentially alkylates all of these proteins here and just causes widespread protein damage to the parasite. And that's how essentially the parasite dies. Before we actually knew the mechanism, a large collaborative group started noticing partial resistance patterns, and particularly starting in 2008 with evidence of artemisinin resistant malaria in Western Cambodia. And this was done with a global collaborative group, including groups at the NIH, which identified these isolates that were truly had delayed clearance, both clinically and also when the isolates were taken in vitro and using in vitro parasite growth assays. And in the last year, these partially resistant isolates have been identified in Rwanda and also in Uganda. This is the subject of the popular press reports that you probably heard about in NPR. And so this kind of goes to the question is, why do resistant parasites, whether it be the chloroquine, SP, or artemisinin, develop in Southeast Asia first before it appears in places where malaria is more prevalent, such as Sub-Saharan Africa. And so there's multiple reasons. There's poor quality anti-malaria drugs. So pharmacies and unscrupulous individuals potentially sell drugs that have just enough active ingredients to reduce the symptoms, but not enough to actually kill the parasites. So there's also incomplete patient adherence. There is this monoclonal nature of PFAS-circum infections in Asia, as opposed to in Africa, where polyclonal infections are probably the norm. And so a parasite with resistance markers has to compete against wild type, which generally has a greater fitness than the mutant parasite. And so there's also incomplete host immunity compared to Sub-Saharan Africa. So Southeast Asia, it's not as whole endemic or hyperendemic as areas in Africa. And individuals who are infected, they don't have the benefit of having their own natural immunity help control the parasite. So the parasite runs, basically replicates unabated and uncontrolled. And also there's been some evidence that prevalence of human hemoglobinopathies that alter erythrocyte redox states, such as thalassemias, can potentially alter the efficacy of artemisinins, given that that depends a lot on the ability of heme to activate the drug. So I go back to the case here, so that this patient had been sent home to complete a 3-day course, but returns the next day feeling more lethargic and was referred to the local hospital, where he was found to be appropriate and able to converse. Exam was remarkable for scleral icterus and palpable spleen, was febrile, normal temperature, slightly elevated heart rate, blood glucose was 58, hematocrit was low, so patient was given glucose and started artemisinin for having a 15% parasitemia. Okay, And so at 6 hours, the parasitemia increased to 22 parasitized RBCs. And then at 48 hours, parasitemia dropped, gradually decreased to 7% over the next 24 hours, rebounding to 15%. And then, so after initial artemisinin quinine therapy, Atovaquone-proguanil was added, and the parasitemia dropped to 5%. And then subsequently, IV antimalarials were discontinued after 7 days after the patient responded both clinically and parasitologically. And so this was a example of a case of what's called delayed parasite clearance, and that it took a long time for it to clear, and they were concerned about not clearing at all. So that's why they add the additional medications. And so the WHO definition again is you have microscopically detectable parasitemia on day 3 after treatment. And the way the WHO recommends how the countries monitor is these therapeutic efficacy studies. And this is like a template protocol where essentially blood is drawn at defined time points after treatment is initiated, and isolates are saved and potentially sent for molecular marker testing to look for resistance. And it's just important to note here that Artemisinin partial resistance rarely leads to treatment failure unless there is identified resistance to the partner drug. And it's becoming more commonplace in the Greater Mekong subregion. And so that's something that WHO and the partner countries are actively monitoring. As far as in Africa, so with the reports in Uganda and Rwanda, it's still believed that Artemisinin combination therapy is still efficacious, but there is some concern, and so there, especially if there's a development of resistance against the partner drugs as well. And so it is something that public health institutions are being more hypervigilant about seeing these cases and seeing how the patients themselves respond after combination therapy is given. And so we'll talk a little bit about Artemisinin resistance and the markers and the mechanisms. And so the markers of resistance were identified back in 2014 molecularly, when it was shown that parasite isolates with particular mutations in what was found to be a protein called Kelch-13 basically had prolonged survival of the ring stage when the parasites were put under drug pressure in vitro. And this matched up with the delayed clearance of the parasitemia in clinical isolates, as shown here. And everything pointed to identify that the C5580Y mutation as the key mutation for resistance. So, and this is in the Kelch-13 protein. And so, as you can see, they identified other potentially important mutations that was associated with elevated parasite clearance, but this was by far the predominant one. And since then, there's been several other molecular markers of Artemisinin resistance that have been identified initially in clinical isolates and then verified molecularly either through transfection studies or knockout type studies. And I just want to highlight these. So the WHO has identified 10 as verified molecular markers, and with C580Y being the most important or most predominant. But I added here, highlighted are the ones that were identified in Rwanda and then 2 that were more recently identified in Uganda. And so the authors of the New England Journal article argued that this met criteria to be a confirmed marker. So I suspect that this will be updated in the WHO verified markers report. And in terms of the temporal trends, this was just published, I think, a couple of weeks ago. And so this is data that's primarily from 2002 to 2018, because 2019 and 2020 data is incomplete. But you can see here that clearly the C580Y mutation is the most common, with other important ones such as the F446I1 is also more abundant than the other ones. And so, we've identified these molecular markers, but we don't know what is the mechanism. And so, as you remember, the mechanism of artemisinin is it becomes activated by heme, and then it releases the free radicals that causes alkylation of the proteins, essentially causing widespread proteopathy. And so a transcriptomic study was done by a group based out of Singapore and in collaboration with other groups globally, found that the parasites that are associated with resistance essentially have increased expression of unfolded protein response pathways, including the 2 major protein complexes, the falciparum or Plasmodium reactive oxidase stress chaperone system, and also this TCP1 ring complex And so these resistant parasites also exhibit accelerated progression through the first part of the asexual development cycle. And it's believed that the parasite wants to slow down a little so that it doesn't cause a lot of too much heme breakdown, which would start activating more artemisinin, which would restore even more of their proteins. So it's a way of just slowing down a bit so that it can protect itself. And so that's just why what they think is the mechanism for the increased dormancy of parasites when they're treated with artemisinin, or the survival of dormant parasites. And another potential pathway is through phosphoinositide 3 kinase, or PI3 kinase. Increased PI3 kinase associated with the C580Y mutation. And so what this does is normally KELCH13 binds to PI3 kinase and falciparum, causes ubiquination and then the degradation. And what the mutant form does is it prevents this from happening, just less ubiquination. And PI3 kinase is able to be more abundant, and at increased levels, it phosphorylates its substrate, PI3P, and the elevated PI3 confers artemisinin resistance in the absence of KELCH13. And so how does this relate to the whole potential mechanism? So this is a very complicated slide, but the main gist of this is that artemisinin causes this proteopathy and this widespread destruction of the parasite protein makes the parasite try to fix it. And so these mutations in KELCH13 helps to do that. So what it does is these destroyed proteins or misfolded proteins, it tries to save them. And so through the PI3 kinase pathway and through this phosphoinositide 3 phosphate, it basically initiates this autophagy pathway. So it essentially tries to save some proteins, breaks them down, potentially reuse the recycled amino acids. And also it tries to refold some proteins that were misfolded, tries to correct them and makes them into native protein again. and so it's essentially trying to repair what damage is there. And so um, having a wild type, it doesn't do that. So if you have the wild type, what you do is just end up, degrading other proteins that were modified by artemisinin, which is this state is not good to basically not recycle or not try to fix these proteins. And so this is a more simplified summary slide. Is that if you have sufficient resistant mechanisms, you restore this folding, remove the aggregates, lead to survival. If you don't have sufficient resistant mechanisms, at least the cell death, because it becomes a catabolic state for the parasite. So I'd just like to bring up resistance in combination therapy partner drugs. For piperacillin, which is also a 4-aminoquinolone, typically used with dihydroartemisinin. And so resistance to this is primarily through amplification of hemoglobinases, plasmodium 2 and 3. And then, as we remember, similar to the mechanism of chloroquine, what piperacillin does is that also prevents the detoxification of heme. And so the free heme is toxic, it destroys the parasite. And so if you have more hemoglobinases, you overcome this ability to inhibit the heme detoxification. Lumefantrine is used with artemether, so that's coartem. Its mechanism isn't actually very well defined, but it has been shown that having this MDR, which is an ATP binding cassette protein, having implication of this gene provides low-grade resistance, so not high-grade resistance. And so lumefantrine is one of the drugs that hopefully we don't develop high-grade resistance to, because it's a great partner drug. As is mefloquine, which is used with artemisinin. It also doesn't have a great resistance mechanism. So, now I think I have enough time, but I'll have one more case. So there's a patient or an individual on a work trip in Western Kenya, 30-year-old malaria naive researcher was taking Atovaquone-proguanil as malaria prophylaxis, develops chills a few minutes after finishing a dinner of chicken and pasta, retires to his hotel room, takes a warm shower, progresses to chills and rigors, and then after covering himself up with blankets, managed to fall asleep, only to wake up a couple of hours later with a high-grade fever, drenching in sweat. Takes naproxen to reduce the fever, suppresses symptoms for about 30 minutes. Thinking that he might have malaria, decides to take 3 more tablets of Atovaquone-proguanil, complete one therapeutic dose, eventually falls asleep. Next morning, he wakes up with a near complete resolution of symptoms from the previous night. He stops by the local clinic to grab a finger prick for an RDT and blood smears, and then heads up to the field to work. RDT is negative. 5 hours later, he receives a phone call from the lab tech, and then basically gives a verbal report of the slide. Patient was started on a 30-day course of artemether. And so highlight this case. The case was me, by the way, but highlight this case of a Atovaquone-proguanil resistance. Resistance to Atovaquone is, so the usual mechanism of action of Atovaquone is it inhibits cytochrome B, and this complex is part of the mitochondrial electron transport chain. So it disrupts the electron transport chain. And so it acts in synergy with proguanil. So in its pro-drug form, it synergizes with Atovaquone. And proguanil also can be converted by CYP2C19 into cycloguanil, which actually acts on the folate pathway, similar to the sulfa medications. And so specific mutations in DHFR can confer resistance to cycloguanil. And then mutations to cytochrome B can confer resistance to atovaquone and also the proguanil part. And so how often does this occur? Across 27 studies, there's very little atovaquone-proguanil resistance. And they do believe that it occurs basically spontaneously within the host, essentially because it can't be transmitted. The parasite, these particular mutations don't survive, or well, parasites with these particular mutations don't survive well in the mosquito, and so can be transmitted. And then the other thing that's notable is parasites carrying this site V268 mutations can have later recrudescence. And so it can occur like 2 or 3 days later. So there probably is a fitness cost so that this parasite is slow growing in vivo, but it basically grows slowly enough, and so it can appear like a couple weeks after the patient was initially treated. And so it's recommended that you use an alternative anti-malaria treatment when you observe this. And then I just wanted to highlight a couple of next generation antimalarials, just to know where the drug development field is going, is that there are newer endoperoxide. So this Artemisinin, which is currently being evaluated in phase 2 trials. Although it's unfortunate, there was a trial in African children that showed that a quarter of the kids developed vomiting within 6 hours, which might have explained why it was had poor efficacy. And then this newer drug, this ATP4 inhibitor, has been shown to be well tolerated in phase 2 trials in adults. And most of what I've done is I've read these couple of literatures, review articles, and then delved through some of the primary literature to get this updated information. I think we have enough time to have a discussion. So I unshare my slides here.
Tuan, thanks so much. Yes, we do absolutely have some time for questions if people want to post them in the chat. And thank you so much. After the publication, particularly of that New England Journal of Medicine article about Kelch13 mutations in Eastern Africa, that's been something that has been, I think, on all of our minds and quite worrisome. So it's good to hear more about it. While I wait for people to type in questions, just a reminder that on Monday evening, it is the Frank Neva Clinical Parasitology Quiz. There are going to be 3 great cases, so we highly recommend everyone tune in. Do we have any questions from the group? Tuan, I love it when people present their own cases as, or at least have a reveal at the end. I assume everything was all right after the coartem.
It was, yeah. It was the first time I had malaria, so it's
not too fun. I guess while we wait for questions, I'll ask one of my own. Are there any scenarios where you would routinely recommend prolonging the course of coartem from 3 days to 5 days, or not using coartem at all and using Malaron, for instance? Or only if the patient sort of failed to clear at 72 hours?
I think from what I've been reading in the cases is that in areas where it's suspected, you basically follow your parasitic very closely, and then at some point you have to make the decision that you would switch to add a second agent on top of it, different mechanism, obviously. And it's that 3-day mark is where you would, mark it as partial resistance and consider. So with Artemisinin base, it truly is a rapid, in usual circumstances, pretty rapid killing. So, but I'm not sure unless in that particular village that you are, it's like the prevalence is so high that you tend to consider using something else.
We had one case of malaria recrudescence this year at Georgetown from a non-immune traveler to Uganda, who we treated with 3 days of Corium and cleared perfectly, actually, and very quickly, but then recrudesced about 2 or 3 weeks later, and then treated with Malaron and did fine. I'm still waiting from the CDC to see if there were any molecular markers of resistance, but I think it was probably because of absorption issues.
Okay. Did you clear by smear or by PCR?
He cleared by smear. Any other questions? I guess it's, I'll just mention, right, in terms of getting the CDC, I think will still do the malaria PCR, even though the parasitology diagnostics have been closed, but you can still get malaria resistance markers, I believe, or at least that's what they told me.
Oh, that's great.
Okay. I guess we don't have any other questions, but in any event, thank you so much, and hopefully we'll see everybody. Oh,
I was wondering what the clinical definition of recrudescence is.
So in endemic areas, you have to figure out if it's reinfection or a true recrudescence versus the new infection. I think in a return traveler, it's fairly easy to say. And so the question is like, if it's an absorption issue, right? So we truly given the medication, did the patient take it? If that's the case, then in a return traveler, it would be recrudescence. In an endemic country, you basically have to genotype the isolate to figure out if it's a new infection, especially in a hyperendemic area. So it's a really hard question to define what's recrudescence versus or new infection.
There was, I guess, just for the group, there was an interesting paper that came out that made some waves at ASTMH. I think it was about 3 or 4 years ago. It was a study out of Scandinavia where they looked at travelers, and they found that particularly men who were non-immune, who had a fairly significant BMI, although not, I think it was even 60 kilograms or more, so not that big, actually recrudesced after their first 3 days of treatment in about 20% of cases. So it's something that's not totally uncommon in travelers. And that was in patients that had received Corium, not in patients who'd received Malaron.
Yes, with Malaron, it's the absorption issue is an issue, and also because of this the potential metabolism issues with the CYP2C19. And so there has been evidence that fast metabolizers might have an issue, because most of the parasites, or a lot of the parasites in endemic countries, are sulfa resistant. And so you're not really counting on that the active drug part acting on the folate pathway, so not so much as the atovaquone acting on this the cytochrome B. And so if you have a fast metabolizer, you won't get the synergy of the proguanil component.
Tuan, I have one more question. Do we think that the novel antimalarial vaccines are likely to also be effective against drug-resistant malaria, or to be determined?
Are you talking about like the ones that are pre-acidic vaccines? Yeah. Like the next generation, like R21? I mean, it's a good question. So there are different mechanisms. So I don't think that it will affect in terms of resistance. So it acts on circumsporozoic protein. So unless there's a correlation, which I don't know of, between Kelch13 and particular antigenic variants of CSP, it's pretty unlikely.
Any other questions from the group?
I have a question if you don't mind. So one of the things that I'm not that familiar with treating resistant malaria, but sorry, there's a lot of background noise, but one of the questions and things that you pointed out was the fitness cost to increase resistance. Do we know if disease severity with the Kelch-13 mutant malaria is as severe, or is it too early to say? I mean, are people getting as sick, or are they presenting any differently? That's after, living longer or what? I just wasn't sure.
So from what I'm reading, that there hasn't been, at least with the the major one, the C to Y mutation, there hasn't been a true fitness cost of that mutation. But whether or not the other ones have been shown, I think that's ongoing in terms of figuring that out. To your point, like chloroquine, the main one, K56T, that had a true fitness cost, and so after chloroquine was not used anymore in Malawi, Marian Laufer, Chris Plow's group published that showed that it reverted to wild type, and that you could no longer see these mutations in the prevailing isolate. So that was a true fitness cost, and I think it might be too early to tell if some of these mutations in Kelch-13 will have a fitness cost.
I'm going to interpret silence as no more questions. Thanks so much, Tuan. We did record this, so we'll provide a copy of the recording afterwards. And if anyone thinks of any questions after the fact, you can email me or Elise and we can pass them on. Thanks so much.
Thank you. Thanks, everyone. Bye.